Good afternoon, Facebook viewers. Welcome to our TIF Talk. Today, I'm very excited to introduce Dr. Keith Goldberg. Welcome, Dr. Goldberg, and thank you for being here with us today. So, Dr. Goldberg is a board-certified American Board of Surgery and fellow of the American College of Surgeons. You're in advanced training in general vascular and laparoscopic surgery. You also have clinical interest in robotic and minimally invasive procedures, and especially the TIF procedure for reflux, right?
Yeah, that's absolutely right. Trying to do everything I can with the TIF procedure.
Wonderful. Well, we're very happy to have you here today, and everybody that joined us today, thank you for joining us. As you all know, this is a live event, and at any time, if you have any questions, please go ahead and type them in the chat box, and we will do our best to answer your questions. So thank you very much for joining us. And Dr. Goldberg, we're going to go ahead and start. Let's talk a little bit more about GERD. Can you give us a scientific explanation to what is GERD and acid reflux?
Sure, I'd be happy to do that. So, listen, that's why we're here today. We're here to talk about GERD, which is gastroesophageal reflux disease. And essentially, it's any contents from your stomach, whether it's acid, whether it's bile, whether it's food, refluxing back up your esophagus where it doesn't belong. Acid reflux, kind of a more layman's term for it. Again, what people are associated with is that acid or that heartburn sensation there.
Perfect, thank you. Doing a little bit of fun thing on our TIF Talks. We call it fact or fiction. So there's a lot of patients that are on here who, there's some myths about what GERD is and what acid reflux is. And so we just kind of compiled a little bit of them, and maybe you can play a little along with us. So first one, fact or fiction. Can GERD impact anyone regardless of age? Fact or fiction?
Oh, absolutely fact. Yeah, it really, anyone from a newborn to well advanced age can suffer from reflux.
Okay. Here's another one. GERD can be a cause of sleep apnea. Fact or fiction?
Yeah, well, actually, one of the unusual cases of GERD would be people that aspirate or people that reflux while they're sleeping, kind of going up and causing inflammation or either coughing, etc. So it can be associated with it.
Okay. So tell us a little bit more. We've got a lot of questions from viewers from Facebook Live and also on our pages, our communities where they talk. Can you talk a little bit about the different symptoms, whether they're typical symptoms or atypical symptoms that someone could have if they're suffering from GERD?
Sure. I like to start off with letting people know that all types of GERD are essentially the same, that GERD is an anatomy problem. It's not an acid problem. It's a problem with the lower esophageal sphincter of the valve not functioning properly. So, of course, the typical symptoms people really think about that are kind of easy are heartburn after eating, an acid taste coming up into the chest or into the mouth. Some of the more challenging ones are just simply upper abdominal pain, which may or may not be GERD. And then some of the respiratory symptoms that you mentioned. So people come to me with chronic cough, clearing of the throat, a sensation of something in the back of their throat. So those are the people with kind of a range of symptoms with GERD.
Sure. Okay.
There are some people that have no symptoms. Go ahead.
Right. No. That's a good point. Some people that don't have symptoms. So how do they get diagnosed that they do have GERD if they're not having any symptoms of GERD?
Well, unfortunately, some of those patients really present with advanced cases because they don't have the symptoms. So, for example, when acid or reflux is coming up the esophagus over years and you're not complaining of typical heartburn, people can get cellular damage. They get damage to the esophagus, something called Barrett's esophagus,
Sure.
or they may present with something like a stricture. All of these can increase the risk of getting esophageal cancer. So that's, of all of these problems, that's the absolute worst one and the one we absolutely want to avoid.
Perfect. Yeah. So can GERD cause esophageal cancer?
The short answer is yes. So GERD can cause and contribute to a type of esophageal cancer called adenocarcinoma. And the way that works is that the acid reflux damages the cells of the esophagus, and the human body, trying to be smart about it, changes those cells. It tries to turn them into a protective cell. Therefore, it doesn't burn as much and you don't feel as much. And that's called Barrett's epithelium. Those cells can then degenerate over time with constant change and constant injury, and they can really just make one small change and form an abnormal cell, or what we call dysplasia. That can then over years potentially progress to esophageal cancer. And of course, esophageal cancer is the fastest growing cancer over the past 30, 40 years in the United States, and it's also one of the worst as far as cure.
Right. I'm glad you brought that up because we get lots of questions about that. Can you talk a little bit about? I mean, I know as a surgeon, you're getting cases generally when they're already either diagnosed with GERD or whatnot, or a little bit further in their disease state. But what do you generally recommend patients that are suffering from GERD? What do you recommend for them to manage their GERD symptoms, even before they even think about having any procedure, medical therapy, lifestyle modifications? What do you generally recommend for that?
Sure. No, listen, I think everyone, and unfortunately, a lot of people, by the time they get to me, they've already been through a lot of these, but we do forget the basics. And so the basics are really living a healthy lifestyle. So one of the causes of GERD can be overstretching the stomach and opening up that sphincter by distending it. So eating your 3 regular small meals, avoiding foods that cause reflux. So if you're able to do that, and you say, boy, every time I have orange juice, it causes heartburn. If you can do without certain foods, certain dietary changes, you can do that. Not eating late at night, because again, more people tend to have symptoms when they're lying down at night. You can actually elevate the head of your bed a little bit, just like gravity help you at night a little bit. And I usually just recommend a couple kind of wide 1 to 2 inch patio pavers or blocks from one of the hardware stores under the head of the bed. Pillows really don't work. Wedges can be uncomfortable if you're actually sleeping up instead of just tilting your bed. So those are some of the general things: activity, exercise in the evening, weight loss. And you always want to start with those things. And of course, tens of millions of people can manage their reflux symptoms if they're mild with those modalities.
Perfect. Thank you. So I hope you don't mind, because we have talked to your wife in the past, and she's given us some patient testimonials. But just for our viewers, some of you that may or may not know, and hope you don't mind that I'm sharing this, but you, as not only a physician but also as a husband, your wife also suffered severely from GERD as well. So you saw her suffer through a lot of the things that you're speaking about, right? So, and then she also had the TIF procedure a couple of years ago.
Yes.
Perfect. Yeah.
Yes.
So we have.
Yeah.
Yep. Go ahead.
Go ahead.
Oh,
no,
so
please.
we have. Yeah. So we have a couple of questions that have come up. We'll talk more when we talk a little bit more about the TIF procedure.
Right.
But so we have a question from a viewer. How suitable is the TIF procedure for someone who has Barrett's along with GERD? You kind of a little bit Barrett's.
Yeah, no, listen, I think TIF procedure for patients with Barrett's is a really important factor. The fact is that even with antacids, with proton pump inhibitors that most people would be on, that has not been demonstrated to get rid of Barrett's or stop the injury. So even though you're blocking the acid, the reflux is still continuing. It just doesn't burn as much, so you may not feel it. So I think it's really important in Barrett's patients to actually look at both. Continuing antacid medication, but kind of belt and suspender, but go ahead and repair the valve if you're a candidate to stop the damage. And then you've done everything that you can do.
Right, right. So there's a lot of talk these days about PPIs and long-term use of PPIs. There was even a couple of weeks ago a report that came out in regards to PPIs potentially increasing your probability of getting COVID. As we all know, COVID is such a high topic these days. Do you have any input on PPI therapy or patients that are on PPI for GERD or reflux?
Well, yeah, really up until now, when we're talking with TIF and some older procedures, the standard therapy is PPI or, Prilosec and those types of medicines. Felt block the acid, takes care of many people's symptoms. So, we have, well over 80, 100 million of patients in the United States taking those medicines. The problem is that they were never really FDA approved for long-term use. So now, after 30 years of using them, we're discovering that there are lots of potential side effects. I know in my practice, I was getting a lot of consults for iron deficiency anemia. And a lot of times, physicians think, oh, well, that must be because someone's bleeding. But the first thing I'd look for is that patient on a PPI? Because basically, I like to believe, and you think about it this way, there's acid in your stomach, right? I mean, whatever you believe, we have hydrochloric acid in our stomach. And it's there for a purpose, and it's there to help us break down our food into the appropriate minerals and vitamins so they can be absorbed. So blocking the acid, there are bound to be side effects. There are a lot of variables, so it's to show that there's potential, things like dementia, heart disease, osteoporosis, and all sorts of vitamins, and the list goes on.
Sure. So it was breaking up a little bit, but you talked a little bit about osteoporosis. Let's talk a little about the TIF procedure. Do you want to explain what the TIF procedure is and how it works?
I've been performing that here in Springfield for 3 years, since 2017. And we've now performed well over 100 of those procedures, and the numbers nationwide and internationally are great, and our numbers here, I think, are even better than the national studies. So I've been very happy with it, and I've got lots of patients out there that have been very happy, really life-changing, especially for patients that medicines don't even work for.
Right. So we do have quite a few questions that have popped up. Hopefully you can still hear me. Just let me know if you can't.
I can.
Okay, fantastic. So you did talk a little bit. You broke up slightly when you were discussing what the TIF procedure is, but that's okay. It kind of caught up and we heard most of it. So what convinced you to start doing the TIF procedure? Was it your patients? Were you frustrated with other options? Can you tell us a little bit about that?
Yeah, well, of course, I do a lot of endoscopy as well. So I have a lot of my patients that have acid reflux, and all I was doing was the same things we talked about. We did the lifestyle, we did the diet, and then it was medications. And if the medications didn't work, then we would, give more medications. About 3 years ago, it was really kind of hitting that the medications were having long-term potential side effects.
Sure.
And patients still had a number of patients that even with those side effects weren't controlled. The older surgeries that we did just have a really high side effect profile. And if you have those patients that you do that Nissen fundoplication on, and if even one of them ends up bloated, they end up, complaining in the emergency room and dissatisfied. And that it breaks it for you as a physician. So I was looking for something new, and I happened upon TIF. it had been around since 2007, but it had really been evolving. And that's what I liked about it. It wasn't something that was created and then we just stopped. So even since I started doing it, the device and the technique have evolved and changed. And that's just completely different from everything else really that's out there. That once it was developed, boom, it was done. The Nissen fundoplication has been done the same way for the past 70 years without any revision. And that's just not appropriate. So
Right.
that's really what it was. You mentioned my wife earlier. In that process, as I went home and mentioned it to her, she got very excited about it. And I said, whoa, let me find out more about it. So as I was researching it, she was researching it too. And, and she wanted to have that done as well. And she's been very successful in that regard. We had another physician do that for her several years ago. And she has been, off medication since, still eats very, very well. Sorry, honey. And then, she's even able to take medicine she couldn't take before. So things like ibuprofen that used to cause severe reflux for her, she can now take ibuprofen if she needs to. So combination of things. And then the amazing thing is as I was trying to get patients off of proton pump inhibitors, I said, well, great, we'll transition them to Zantac. And all of a sudden, Zantac is off the market. And then follow that with Tagamet off the market because no one has Zantac. And really, at this point, we're left with Tums and Pepcid.
Right.
We just don't have a lot of options anymore. And, other than these medications. And then finally, I started really thinking about it, and especially, in all patients, whether you're 30 or whether you're 60, you're going to have years and years of being on these medications. And really, if you have an option for something to actually fix the problem and not just treat the symptoms, I was really sold on that. And my patients, like I said, I think have been very thankful for that.
Wonderful. Gosh, I couldn't have said that any better. We do have some questions, and you had mentioned endoscopy, that you do your own endoscopies. Question here is, what tests are required for a TIF candidate?
So every patient is different, and I think that's really important. My absolute minimum would be, someone who has classic symptoms, who responds to the medication but either doesn't want to be on it or it doesn't give them full control. If we do an upper endoscopy, take some measurements, and there is evidence of reflux. And then finally, just a swallowing x-ray to make sure that the esophagus is moving appropriately. That's the absolute bare minimum in the perfect candidate. Most patients, I recommend a few other studies, something called the Bravo pH probe or an acid probe to measure the reflux. I think that's a great tool. And so I offer it to my patients on their first endoscopy if we are thinking about doing a procedure to save them a step, because I can do that on our very first endoscopy. Those are the main ones. There are others. Depending on the patient. Patients with a lot of bloating or abdominal discomfort, you want to make sure their stomach is working properly. So there's some stomach emptying studies, and very rarely some pressure testing studies in the esophagus.
Okay, thank you.
Yeah.
Sorry, there's tons of questions popping up, so I'm trying to read them as fast as I can, and we will do our best to answer them. What about a hiatal hernia? That's a big question that always comes up. Can I get the TIF procedure if I have a hiatal hernia?
You can absolutely get the TIF procedure with a hiatal hernia. Now, you can have a TIF procedure without incisions completely if you have a small hiatal hernia, because the esophagus device can reduce small hiatal hernia. So it's absolutely FDA approved and shown effective for that. I use laparoscopy. I have 5 less than 1 centimeter incisions, don't bother anyone. The diaphragm, which is the hiatal hernia port, would rather do everything at once. Go ahead.
Sorry, it was cutting out again in between, but what I think you were saying was that, if you can still hear me, that you do the hiatal hernia repair and the TIF procedure at the same time, correct?
Correct.
Yeah.
Correct.
Okay. And if they have less than 2 centimeter hiatal hernia, then you can just do the TIF on its own and everything, correct?
That is correct. The data is very good for that.
Fantastic. Wonderful. So another question that we have is esophageal manometry required or suggested? And I think you talked a little bit about that, right?
Yeah, esophageal manometry, I didn't say it by name, is very uncomfortable. Most patients hate it. You have to be awake. It's a pretty stiff tube going down to the nose, through the nose into the esophagus. So I think a lot of facilities and a lot of physicians have gotten away from it, as long as the patient doesn't have significant difficulty swallowing. And as long as the swallowing x-ray is relatively normal, then I usually don't do manometry.
Okay, thank you. Another question, if the esophagus is damaged, inflammation, irritation caused from GERD, can it heal after the TIF procedure?
It can, absolutely, because the goal is to stop the acid and the damage exposure. So absolutely it can, and it should.
Okay, great. And we have a comment from a viewer. It's great to hear that the doctor's wife is doing well after the TIF procedure. So yes, it is great to hear that.
It is great to hear.
Yes, yes, yes. Let's see. What does the recovery time from the TIF look like, specifically for you and your patients?
Sure. So, the recovery time I would say is about a week. And really, 2, 3, 4 days, you're probably feeling pretty good. There is a prolonged diet that we recommend. Now, every physician is a little different. It's a little nuanced, but I would say very similar to, let's say, any other minimally invasive procedure. By 1 week, you feel, pretty good. And by 2 weeks, you feel really good. There are going to be some, like I said, some dietary changes initially.
Okay. Can you talk a little bit more about the post-op instructions that you usually give patients? What does the diet look like? How can they go back to work? Can they exercise?
Yep. Yeah. So first of all, they can go back to work as soon as they feel like it, depending on their job. Now, if they do a heavy job, a heavy lifting job, then I'm going to recommend they be off for 6 weeks from anything really heavy. So that is a problem for people that have an active heavy duty job. But we want all of that tissue to heal and repair so that this will last for you. Just like any other hernia surgery or any other minimally invasive surgery, we want everything to heal up the best we can. And so 6 weeks. As far as any other activity, my criteria are that you don't require any significant pain medication, that you feel good, you can go back to work. So, and I called them out of state to make sure they were doing okay. But typically 3 to 5 days for kind of light procedures and whatnot would be aggressive. It really depends on what you need to do. If you work from home, especially now during kind of the COVID pandemic, perfect, because you can Zoom all you want after the TIF procedure. Okay. The diet, again, fluctuates, but typically it's going to be a liquid diet, a full liquid diet, small volumes frequently for 2 weeks. Initially, it's going to be very swollen, and you are going to have some difficulty swallowing initially, but we want all of those sutures, those serosive fused fasteners, for everything to heal before we stress that area. We want the swelling to go down. Usually at about 12 days to 2 weeks, I see my patients back, and if they're having no problems with that, we move them to a soft diet. And so that's going to be things like pastas and egg. You can continue the full liquids, protein shakes, yogurts. I do move them usually to kind of a real soft chicken salad, well-cooked pastas, and well-cooked vegetables. And really and slow progression up to about 6 weeks. And I tell my patients, no sandwiches, no sub sandwiches, no steak, chicken, pork chop, anything like that for at least 6 weeks. We just want to make sure that you're swallowing well, that everything's healed up, so as not to have any discomfort.
Okay, so do your patients still take PPIs right after the procedure? Do you? Yeah.
Sure. So what I do is I let them continue their PPI certainly for the first 2 weeks after surgery, make sure they're doing well. Any esophagitis that someone mentioned, any reflux changes they had before, we want all of it up. After that, it depends. So, Barrett's patients we talked about, I continue, but all other patients, I allow them to discontinue. It is possible that if you've been on them for a long period of time and you just stop them, that you could have a rebound of acid. So oftentimes I'll recommend that they slowly decrease them and wean themselves off over the upcoming weeks.
Okay.
It varies, but patients can definitely just stop them. If they do fine, they can just.
Okay, wonderful. We've got another physician watching today. Hi, Dr. Thome. So he's agreeing with you on a couple of comments that you made in regards to, manometry, and he's also answering some questions. So thank you for being on and watching the TIF Talk today. So last thing before we finish off, can you, I know you talked about your wife a little bit and her experience with the TIF procedure. Do you have any success stories or anything that you'd like to share with our Facebook users? Any great examples of why the TIF procedure is your procedure of choice for GERD or reflux?
Oh, absolutely. I mean, I've got lots of patient, examples. Some of the ones that, without giving patients names, of course, some of my favorite were just a terrific gentleman early in the process who used to travel on business and would carry a wedge around with him to all the hotels. And so we ended up evaluating him, treating him, and he was completely cured of his reflux. And then several months later, he brought his father in because he said, well, my father's having the same symptoms. I think he needs a TIF. And as I assessed his father, I realized his chest pain was not reflux. And I instructed them to immediately go to his cardiologist. And it was one of the first times that I've ever received a letter back from a cardiologist thanking me for saving his life because the gentleman had been having angina and was about to have a major heart attack. And so he went right into surgery and had a procedure done. And so, again, it's important when patients wonder why they have to have all of this testing and the appropriate testing. We need to make sure that you're the appropriate patient, and that we're doing the appropriate procedure for you. And one other comment on that, because sometimes, I'm online, I watch people saying, oh, this didn't work for me and that didn't work for me. And I always want them to come see me. Because sometimes I wonder if they actually had the right procedure for the right disease. And it's really important for them to work with their physician on that.
Yeah, no, that's great. Wow, what a story.
Yeah.
So I guess this is a question that gets asked all the time. Is it safe right now for patients to come in for these types of diagnostic testings or get the TIF procedure, given that the COVID situation? So maybe
Sure.
you can talk a little bit about the precautions that you're taking at your hospital and what your thoughts are on the safety of coming in for those types of procedures or diagnostic testing.
Sure. Well, first of all, here in Springfield at Northcrest, I feel that it's been very safe. Of course, we took time off as well during the initial peak, and instituted a lot of safety precautions that people are doing around the country. So whether we've been, fortunate that they've been successful, we've not had patients contract COVID from any of our surgeries or our procedures. And here's really the important part. So, it is safe here to do. You're going to have to base that wherever you are on the risk in your area. But I want to say this, that the week after we started doing elective procedures at our facility, that very first week, I diagnosed 2 patients who had been put off from their elective colonoscopies who had colon cancer. And so it's really important for us not to neglect patients. COVID is not the only disease out there. It is important. I mean, we're watching it closely, and it is possible that we would be shut down from elective procedures again. But it just reinforces to me that if someone's having chest pain, esophageal cancer, could they have a stricture of their esophagus? So don't neglect.
Sorry, you were cutting out just a tad, but I think to your point, that is very, very important, especially for this audience that we have, is don't neglect your health. regardless, right? And now's the time, and it's safe to go into your doctors. I've even talked to some physicians where they say, you're safer to come into, my office or the hospital at certain locations, obviously, than it is for you to go to the grocery store sometimes. So, that was a really good point. We did have a question that I wanted to try and get your thoughts on. What are your thoughts on doing a TIF on patients who previously were diagnosed with low-grade dysplasia or high-grade dysplasia, but had been treated with either cryo or RFA and achieved CRIM?
Yeah, I think those patients, if they meet the criteria, I think those patients definitely should have TIF. Yeah, they should definitely have a procedure to stop further damage.
Perfect. Thank you. So, well, that was all of the topics that we were going to discuss. Was there anything else that you wanted to share with us? Oh, also, can you tell us where you're located, your offices, and also how can someone in your area reach you? Is it best to call? I believe, yeah, we do have your number on the screen right now, but tell us again what areas you're located. You just opened a new practice, right? In Henderson.
Yeah. In Hendersonville. So we're located around Nashville. So Nashville, Tennessee. And, we used to be a great place to visit. Hopefully we'll be again soon. So my facility is just north of Nashville, where I've been practicing for 20 years. That's where I exclusively have been performing the TIF procedure the last 3 years. We have an office in Clarksville, and we have an office in Hendersonville, so kind of northern middle Tennessee. The office number is probably the best way, just to call and make an appointment, and just come in and see me, one of my trained nurse practitioners, physician's assistants. They can all get you on the right track and get you set up. And again, try to do the right thing for you. And again, if you've had a problem or a failure of something in the past, I'd urge you to come here. I've had patients from a number of different states come in, from Alabama, from Mississippi, from Kentucky, of course, which is fairly close. And if you just want another opinion, then I'm happy to provide that opinion as well.
Perfect. We did have one other question that just popped up, and they're asking, do you use the second or third generation esophageal device?
I use the newest generation. They're actually about 5 or 6 evolutions, and I'll tell you, even when I started, since then I had made little adjustments based on physician and patient feedback. So they're very responsive to making it continue to evolve and continue to be even better.
Perfect. Thank you so much. So again, if you're in the Tennessee area or around that area, even further out, you all can visit or call Dr. Goldberg. His number is on the screen, so feel free to give his office a call and they can schedule an appointment. If you're not in the area and you're looking for a doctor, a TIF specialist, you can go to gerdhelp.com. On there is a physician finder. You can search by state and or by zip code, and you can just pop in your zip code and you'll be able to find a physician that is near you. Dr. Goldberg, I can't thank you enough. I know we had some technical difficulties tonight. I apologize, but hopefully you got all the information, viewers, that you needed or wanted, and answers to your questions. And again, Dr. Goldberg, thank you so much for joining us. We really appreciate you taking the time to educate these potential patients more on GERD, on the TIF procedure, and also answer all the questions that we have. So with that said, thank you very much, Dr. Goldberg. I hope you have a great evening. Yeah, thank you. Everybody else, please stay safe, and we'll catch you next time. So thank you very much. Have a great night.
Good night, everyone.